Okay. Hi. Hello, everybody. Welcome to the second SAPHIR'S monthly scientific webinar. Today, or for most of you tonight, we have participants from all around the world. We have folks from Tehran, Kerman, Bushehr, Mashhad, Sanandaj, Shahrud, Sydney, Cairo, London, Cambridge, Vancouver, San Francisco, Davis, New York, DC, Boston, Baltimore, Medford, Providence, and Newton. My name is Siamak Mortality, a member of SAPHIR'S Board of Directors. I'm initiating this webinar from Boston. We will have these webinars on the second Friday of each month. As you may know, SAPHIR, the Scientific Association for Public Health in Iran, is a non-profit membership-based organization based in Cambridge, Massachusetts, and that aims to create a global network to generate and disseminate public health knowledge regarding Iran. You can learn more about organization by checking saphirnetwork.org, saphirnetwork.org. During the webinar, please make sure to mute your microphone to avoid any background noise, including typing your notes. Each slide has a number, so if you have a question regarding any slide, please make sure to write down the number of the slide so we can discuss it after the presentation. When it's the time for Q&A, please raise your hand. There is a little icon as hand, so simply you can raise your hand and we will get back to you in a first come first serve. The total time of the webinar is 1 hour. We record the webinar and we will publish it, including the slides, in our website. And now, we are delighted to have a very distinguished scientist with us to give us a presentation, Dr. Farin Kamangar. I'm sure most of you know Dr. Kamangar from his publications and his achievements during his intensive work on health issues. Dr. Kamangar is a professor and chairman of the Department of Public Health Analysis, School of Community and Policy at the Morgan State University. Farin was graduated from Tehran University in 1996 as a medical doctor. He received his MPH from Tehran University in 2000, his MHS in biostatistics, and PhD in epidemiology from Johns Hopkins in 2005. So far, he has published over 100 peer-reviewed papers. He has received 17 awards. He has done paper review for more than 50 journals and many other scientific achievements. Dr. Farin Kamangar is a member of SAPHIR'S Board of Directors as well. Thank you very much, Farin. It is delighted to have you as our presenter. We are all ears to listen to your presentation. Thank you.
Dear Siamak, thank you very much for your very kind introduction. And thanks to you who have attended our today's webinar on opium use and mortality in Iran. I am presenting the results on a prospective cohort study of 50,000 adults in Iran. Obviously, this is not just my work. This is a work that has been led by many other scientists and many of my, there are many colleagues who have substantially contributed to this work. So I'm just presenting on their behalf. This is the outline of my presentation. I would like to talk to you about the significance of the study, its objectives, Goldston cohort study in which the study was conducted, statistical methods, results, discussion, and lessons learned and suggestions for further research. I would like to do this presentation in about something like 35 to 40 minutes, and after that I will take questions. First, significance of the study. Opium and opioids have been used for recreational and medicinal purposes for a very, very long time. And it is estimated by United Nations that 13 to 22 million people around the world used opium or its derivatives in 2008. And it has been used in many areas of the world. The next few slides shows this. Opium has had recreational purposes, medicinal purposes. It has been part of the apothecary, what they have been using to treat people. It is used in many parts of the world. These dots that you see shows the main places that the production of opium is being done. And as you see, basically in Afghanistan, which is very close to Iran, has one of the main parts of the production, and I guess we all know that. And as I mentioned, has a very long history, as you see from this picture that shows the goddess of opium. We even see opium used in Tintin. So it's almost universal. But despite this very long history of opium use, very few epidemiologic studies of chronic opium use and health have been conducted. And they are mostly limited to case control studies. I'm going to show you some of those studies that have worked on opium and health. For example, a study by Qadirian in 1985 and another one by Nasrullah and colleagues, in 2008, showed that opium may increase the risk of esophageal cancer. And I emphasize that I say may increase the risk of esophageal cancer because there are lots of factors that, such as confounders may exist, such that we are not 100% sure that these associations are causal, but at least there are associations. It has been shown to be associated with increased risk of bladder cancer in multiple studies. It has been shown to be associated with increased risk of laryngeal cancer. And two other cancers, and because these two other cancers have not been published yet, I'm going to leave it as that. The previous slide was on cancers, but opium has also been shown to increase the risk of cardiovascular diseases in several studies. And as you see, most of these papers are from Iran, Sadafyan, Masumi, and so on and so forth. And deep vein thrombosis and lung diseases. So, as you see, the number of studies are very limited. And all of them, almost all of them, are case control studies. To my knowledge, there had been no large-scale or long-term prospective study of cohort study of opium and health until recently. This was the research gap. Therefore, we conducted a study using data from Golestan cohort study, which is a cohort study of 50,000 people, to determine the effect of opium use on overall and cause-specific mortality, and to determine this effect by type of opium use. For example, is it teriyaq or shire or sukhte or heroin, how they affect health of people. Next, I would like to talk about Golestan cohort study in which the study was conducted. Golestan cohort study is in Golestan province in northeast of Iran. 50,045 adults ages 40 to 75 years of age were enrolled into this study. And significant amount of data has been collected from these people. There are detailed questionnaire data on general questionnaires and a food frequency questionnaire that was basically designed solely for this study. And also biologic samples were collected, like blood, urine, hair, and nail. You see some pictures of the samples from this study. For example, you see the straws on your upper left hand, and these straws are used to collect blood samples and be put in nitrogen tanks in France or in -80 freezers in Tehran. That circle that you see shows the site of the study, which is in northeastern Iran next to Caspian Sea. One might ask why so much resources, 50,000 people and such a huge data collection, was done in a relatively small area of Iran and relatively remote area of Iran. I would like to talk about the history of this cohort a little bit. The reason the cohort was done there is because that area has been historically known to have very high rates of esophageal cancer. The story goes back to almost 50 years ago, to 1960s, when there were anecdotal reports from central institutions in Iran by Habibi, and other colleagues, in which they reported that it seems that rates of esophageal cancer in that area of Iran is very high. Then there were exploratory observations by people from IAR, which is part of WHO, including Janis Kemet, who went to Iran, and he also confirmed that the rates of esophageal cancer were very high. So IAR started a cancer registry in the area from 1968 to 1971, which basically was the initiation of several studies in 60s and 70s called Iran IAR studies. As you see, when they conducted the cancer registry, they realized that the rates were very high, in fact. In area around Gombat that you see on the right-hand side, the area that is black, you see that the rates are extremely high. And you see 109 and 174 on the most right-hand side. 109 per 100,000 is rate in men, and 174 is rate in women for esophageal squamous cell carcinoma. Rates in the United States are, for example, let's say 4 or 5 per 100,000. So these rates were like 30 times higher than what you see in the United States. So these are very high rate areas. Once you move toward west, meaning to your left-hand side, you see that rates go down to 95, 61, then 17. Then you go to areas that, rates are 9 and 4 and 20 and 5 and of that nature. So the rates dramatically decline in 500 miles. This was really interesting to the researchers, why rates are so high and then they decline. The other thing that was interesting to researchers was that, as you see, in the very high-risk area, rate is 109 for men, 174 for women. So esophageal cancer was basically more common in women than in men in that area. And this is very different from what you see in other parts of the world in which, esophageal cancer is higher in men than in women. So basically the registry results showed that rates are they were the highest rates ever reported in the world. Rates were high also in women, and there were large differences in rate across the 500-kilometer area. After they had the registry results, they started doing ecologic studies, comparing high-risk areas with medium-risk areas with low-risk areas. Obviously, there were lots of differences. There are differences in fauna and flora. There are differences in foods consumed, like sheep's milk or vegetables or sesame oil, or etc. They realized that in high-risk areas, they were using tea at a higher temperature, perhaps. In very high-risk areas where, Turkomans basically lived, people chewed nas, which is a mixture of ash and lime and tobacco, but that chewing of nas was not common to low-risk areas. So they said maybe nas is a risk factor. And another thing that caught their attention, and I have it in red here, is that opium use was very, very high. It was up to 50% in both sexes over 35 years of age. And that caught their attention, that they wanted to do studies on all of these, including opium. After doing the ecologic studies, they moved to a case control study in which they had 350 cases of esophageal cancer and 700 controls. And they realized much of what they saw in the ecologic study was not associated with esophageal cancer. For example, using sheep's milk or sesame oil or pregnancy diets or NAS, they were barely associated or not associated. Cigarette smoking was associated with risk of esophageal cancer, but the risk was less than twofold. In other areas of the world, it's usually 4 or 5-fold. So it was less strong than other places. Low intake of fresh fruit and vegetables was associated. Low socioeconomic status was associated, and drinking hot tea was associated. They did not assess opium use in this case control study because they were not sure that the people would tell them the truth about their opium use, so they left this one out. I have to say that these studies were really seminal studies. They published several papers in Lancet, in Science, this one you see in British Journal of Cancer, and several epidemiologic statistical methods were developed for these. For example, conditional logistic regression was mainly developed to analyze the studies of these for Iran, and Norm Breslow developed those studies. So these studies were in medical literature for a long time. As I mentioned, opium was left out from the initial study, but there were further studies later. They looked into crude opium, suchte, which is opium pipe residues, which poorer people used because who could not afford opium, and they realized that there were in Aimsters there were mutagens in suchte, which basically said that it might be carcinogenic. And they also looked at shira, but they did not find mutagens in shira. They later went on and did a case-control studies of families of people with esophageal cancer and those who did not have esophageal cancer, and they measured opium metabolites in the urines of family members, not cases, because they wanted to know if there is an association between opium use and esophageal cancer of family members of people who have got esophageal cancer. This study was going well, but it remained half complete. The results of this half complete study showed a non-significant but twofold increased risk associated with esophageal cancer risk. And this was published in 1985 in the International Journal of Cancer. The reason the study remained half complete was the 1979 revolution of Iran, after which the Iraq scientists left Iran and studies remained incomplete. Basically, there was a hiatus from 1979 to 1995-96, during which no further studies were conducted. Studies from up to 60s and 70s, this is the summary of what they found back then. That northeastern Iran is a really very high-risk area for esophageal cancer. Risk is similar in men and women. Smoking was a risk factor, but a weak one, and alcohol consumption was very uncommon. And they found some suggested risk factors: low socioeconomic status, low intake of fresh fruit and vegetables, hot tea intake. But none of them were very striking. Each of them usually increased the risk by almost twofold. And the reason I say suggested risk factors is that they were only in one case-control study, and there were no further confirmation studies. Opium, there was some suggestion from the second case-control study, but as I mentioned, the study remained incomplete. Around 95-96, Dr. Farouk Saidi, who was a Harvard-trained surgeon working in Shahid Beheshti University, resumed the studies by recruiting a group of motivated medical students from his university, went to Gumbat, and started training people about esophageal cancer, and they started some screening studies. Later, Dr. Reza Malekzadeh, who was a former Minister of Health, went to NCI, met with Stanford Dawsey on his left, that you see, and they started, talking about doing further studies of esophageal cancer in Iran. Dr. Dawsey had already been doing epidemiologic studies of esophageal cancer in China for many years. Dr. Dawsey and his colleagues came to Iran. This is when I got involved in the study, and there was many meetings of, how to resume the studies. And the idea was to start from a case control study. I'm going to talk a little bit about the case control study because it is the sister study of the cohort study, and methods are pretty much similar. The basic idea of the case control study was to reevaluate the previous hypotheses, including opium use, hot tea intake, low socioeconomic status, fruits and vegetables, to test new hypotheses like animal contact, oral hygiene, genetic studies, and to use new technology, genotyping capabilities, proteomics, which were available in 2000s but not in the 1970s. So this was the main reason that we started the case control study, and as you see, opium use was one of the components of the case control study. The study was conducted in the area that you see is shown in black here, the area that with the highest rates, which is Gombat and the surrounding villages. The plan was to recruit 300 esophageal cancer cases and 600 matched neighborhood controls, matched for age, sex, and neighborhood of residence. Team building started. Questionnaires were developed. We were going to have a general questionnaire, a food frequency questionnaire, which was validated for this area and developed for this area, to collect blood, hair, and nail from the samples, and also biopsy samples from esophageal cancer cases. This is what the general questionnaire included. It was quite extensive. It included demographic characteristics, residential history, occupational history, etc., etc. And it included, obviously, information on opium use, because that was one of the presumed risk factors for esophageal cancer. Data was collected on ethnic background. As you see on the left-hand side, close to half of the people in the area are from Turkmen ethnicity, which are perhaps descendants of Turkic groups who moved from China to the area, and half were non-Turkmen. Just as you see on the right-hand side, you see the picture of a Kurdish girl. We develop, how the study is going to be done exactly, and how people are going to enroll. But at the same time, we didn't have a clinic at the time. So Dr. Malikzadeh, who was the leader of the study, established a ATRAC clinic. He and his colleagues established a clinic called ATRAC Clinic to see people with upper gastroesophageal cancers. He went there to do the training along with many colleagues, and training for the physicians in the area, motivating them. And it was always a question how you were going to do this, because why would the physicians in the area would refer their patients to you if that's going to lose their money? Dr. Malikzadeh and his colleagues came up with many ideas. For example, he trained the physicians there, some internal medicine physicians, to do endoscopy. And they could come to ATRAC Clinic, the internists, and do the endoscopy themselves so that they don't lose their patients. That motivated them to refer the patients. He had to speak with people in the university and start research collaborations with them so that they also benefit from the study. He started speaking with the leaders in the area, including religious leaders and government leaders, and made sure that they are happy with this. It is really, really important for those who want to start a cohort or any research effort or any big effort to see what people want, what their desires are, and see what their motivations are so that they collaborate and the study is sustainable. Unfortunately, the study has been sustainable. As you see, my colleagues from NCI went there and tried to make sure, and databases and everything is done well. And recruitment of the case control study started in 2003 and was completed in 2007. 300 cases and 571 matched controls were recruited, and several papers have been published. I'm not going to go over the results of these papers, except one of them very, very quickly, which was on opium use and esophageal cancer, in which you see the results quickly here. Compared to people who use neither tobacco nor opium, tobacco increased the risk of esophageal cancer by 70%, relative risk 1.7, significant. Opium use only increased the risk by more than twofold, again significant. And if you use both tobacco and opium, the risk was again further increased. So this study confirmed that opium is a risk factor perhaps for esophageal cancer. This is a picture of an opium poppy. Beautiful flower with opium including. So while we were doing the case control study, some people from WHO, from IARC, who were initially involved in studies in the 70s, they wanted to have a share in these studies. But the case control study, people have already talked to people at NCI. So the idea, Dr. Malikzadeh suggested that we start a cohort study. At the time, I was entirely incredulous. I didn't think that we would be able to do a cohort study in that area. It's 50,000 people in a remote area. That takes a lot of facilities and people who need to training. But Dr. Malikzadeh went ahead, with his leadership and said, we're going to do the cohort. And despite my pessimism, it materialized. So the Cohort study was designed to enroll 50,000 subjects from eastern part of Golestan province, the same area that the case control study was done, the very high-risk area. The design was very similar to the case control study, the same general questionnaire, the same dietary questionnaire, blood and hair and nail collected. Here we also collected urine because we had some uses for urine in the laboratory. This shows that the blood was basically separated into plasma, RBC, Buffy codes, and they were put in straws or kept in -80 freezers. Urine samples for measuring pH and opium assays were also used in -20 freezers, and half the samples were in Iran and half in IARC in Lyon, France. This shows the nitrogen tanks in Lyon, France that accommodate the samples. The outcomes for this Cohort study was total death from any cause, incident cancer at any site, but because this is a high-risk area for esophageal and gastric cancers, there was emphasis on esophageal and gastric cancers. Outcome assessment, all relevant data were collected from hospitals and clinics, and 2 internists assigned codes. If these 2 give the same code to the cause of death, that is confirmed. If not, a third more senior internist will look over the data and makes the final cause. For esophageal cancer and gastric cancer, an international panel of experts will look into the data to confirm that everything is correct and they are indeed esophageal and gastric cancer and what type. Recruitment of the Cohort study started in 2004 and was completed by 2008, but to date the follow-up continues. It is very important to have a good system for a Cohort study, follow-up of Cohort study, and I believe it is excellent in this cohort. We have phones from all the participants. About 98% of them have phones, and they are called annually by the staff members of the cohort. We have phone numbers from relatives and friends in case we cannot reach the study participant himself or herself. If after 7 calls during 2 weeks the person cannot be reached, there are home visits by a staff member of the Cohort study. They go and follow them. And in rural areas of Iran, there are behvars who are the local health persons in the villages, and they know everybody and they go follow them. So with a combination of these, the follow-up success has been over 99%, which is quite considerable. Up to May 2011, and I'm talking about May 2011, about a year ago, because this is where the opium data when the opium data was analyzed. There were 234,000 person-years of follow-up with over 99% success rate, and 2,145 deaths out of 50,000 occurred in the cohort. By now, we have over 280,000 person-years of follow-up. Again, success rate is over 99%. The case control study and the Cohort study together, they were called Gemini. Gemini standing for twins, because these 2 studies were twin studies, but also it stands for, Gemini stands for gastroesophageal malignancies in northern Iran, which we owe this abbreviation to Dr. Ali Reza Safir. I thought that was a very interesting abbreviation. Now, I'm going to talk about statistical methods and analysis of the opium study, which is nested within the Golestan Cohort study. We use Cox proportional hazard model to estimate the hazard ratios and 95% confidence intervals, with adjustment for potential confounders and assessment of interactions and several sensitivity analysis, which I would allude to later. The main exposure of the study was opium use, and we had data on type of opium use, teriyaq, shireh, sukhte, heroin, and we had the typical amount of use in nohot, which is about 0.2 grams if they used, let's say, 3 nohots or 5 nohots per day. How many years they have used it, the duration of use, and frequency of use, how many days per week they use it. The main outcome of the study was death overall and causes specific. There was a list of potential confounders and effect modifiers such as age, age could be reasonably a confounder because it's associated obviously with death and is associated with opium use. Older people are more likely to use it. Sex, place of residence, ethnicity, marital status, educational level, cigarette smoking. Again, cigarette smoking is a very potential confounder as it is associated with death and is associated with opium use. Body mass index, height, consumption of fruit and vegetables, socioeconomic status, etc., etc. I have to say that there were lots of pilot studies before the case control and the cohort studies started. For example, we put questions in the questionnaire about opium use, and we asked people to self-report. We were not sure if people would tell us the truth because we thought, how do we know that they tell us the truth? Some of the physicians in the area told us, because this is a cohort of older people over 40, they will tell us the truth about opiate use because people have been using this for a long time, and if a medical team goes to them, they will tell you the truth because there's not much stigma to it. But, we couldn't say that. We were not 100% sure that was true. So we did a study of self-reported opium use versus opium metabolites in urine. And we realized that, the sensitivity and the specificity of opium use compared to urine metabolites was over 90%, and we published the results. So we thought, people are really telling us that they are using opium, which is pretty good. There are studies of, the feasibility of the cohort, and as I mentioned, there was a food frequency questionnaire developed for this area, and for this study, the results of all of these have been published, and there are other pilot studies which I do not mention here. Now let's look at the results of the opium in relation to total mortality in this cohort. 50,000 participants, 234,928 person years of follow-up, median follow-up of 4.7 years, and mean age at enrollment of the study, people were 52 years old. Cohort participants were more likely to be women of Turkmen ethnicity. 70% of them had no formal education, completely illiterate. 17% were smokers, and 17% were opium users. As you see, close to 8,000 people out of 50,000 people were opium users. So that's very considerable. And if you think about it, why it is so high, it's quite obvious because this shows the distribution routes or the golden route of opium use. It's mainly produced in Afghanistan, and goes to Pakistan, and from there to Iran, Turkey, and Europe. It also is distributed in the area that we are doing the study, and people traditionally have been using that. This slide from United Nations shows that the majority of opium use, this is not opioids, just opium use. Iran is the largest consumer of opium in the world. 42% of it, as you see, the big pie is used in Iran. So I wouldn't be surprised that most of the studies of opium use in health have been done in Iran, because Iran is a place that has very high use and also has the infrastructure to do epidemiologic studies. See a picture of opium use. So the results with all-cause mortality, hazard ratios and 95% confidence interval. Unadjusted hazard ratio was 2.26, which was quite significant. After adjustment for age, sex, smoking, and a lot of other factors, hazard ratio changed to 1.86. So it shrank, but it was still quite considerable, close to twofold, and it was statistically significant. So the results of our study show that opium use almost doubles the risk of death. And the risk was much stronger than cigarette smoking. Cigarette smoking was 1.3, 1.4, something of that nature for all-cause mortality, but we have 1.86 here. So this seems to be an important risk factor for death. When we looked at the results by subcategories, as I mentioned, for overall it was 1.86, but for circulatory causes, including heart diseases and CVA, it was 1.81. For cancer overall, for all cancers, was 1.61. This is death due to cancer, not all incident cancers. For respiratory causes, it was 3.78. Actually, the strongest association was with respiratory causes. With digestive diseases, 3.12. Well, infectious was also very strong, 5.47, although the confidence interval was very wide because we had fewer numbers. External causes, which is accidents and trauma and that kind of nature, was not associated, but with other or unknown causes also increasing the risk. So you see that opium was increasing the risk of almost everything, which makes you a bit suspicious about, is this real or is this confounded? So we did a bunch of other studies. We looked at by opium use by duration of use. In never users, the risk, which is the baseline, we considered a hazard ratio of 1. Former users was 1.27, current users 1.7, and basically there was a trend with higher use of opium. Overall, if you use it for a longer period, it was more likely that the person died because of opium use. So there was a dose response trend. We looked at the results by use by time since last used opium. So those who never used opium, they are the reference group 1. Those who are current user, the risk is almost twofold. And in between is for people who have quit opium use. For people who quitted less than 5 years ago, it's, let's say, 1.8. For people who quitted 5 to 9 years ago, it's 1.5. So you see a clear dose response for cessation of exposure by time since it was last used. We did other types of sensitivity analysis and subtype analysis. For example, we realized that teriac, shireh, and heroin all increase risk. For heroin, heroin has had by far the largest risk, and we are not surprised by that because, people who are heroin users, they are very different from other people in many ways. But people who use teriac and shireh, they both, had almost doubling of risk of death. Both smoking and ingesting opium increase risk. Some people smoke it, some people ingest it. Smoking opium exposes you to a bunch of things, including polycyclic aromatic hydrocarbons that ingesting does not. But ingesting puts you in risk of getting more morphine, because when you smoke, a lot of the residues stick to the wall of the smoking device, and some of this evaporates in the air. But ingesting, basically, you take in the whole morphine that is available in opium. When we were not sure that this is reverse causality or causality, because opium has been used for medicinal purposes and to alleviate pain in that area. So it is possible that people, when they start having pain from a chest pain, let's say, they start taking opium. So we thought that might be the case. So we did a bunch of sensitivity analysis. We excluded death that occurred in the first 6, 12, 18, and 24 months of follow-up, and it had little effect on the results. When we adjusted for having different diseases and things of that nature, didn't change the results. We did a healthy sub-cohort. By that I mean we looked at people who had never any history of cardiovascular disease or diabetes and things of that nature at baseline, and again opium increased the risk of death. The other thing that we also did is that we asked people about their major disease and when it started, and what we did is we looked at opium use before they had any major diseases, and again, it started at death. So all the sensitivity analysis that we did, basically came down to the conclusion that opium seems to be a risk factor for death by itself, and it is not confounded. Let's go to some discussion of the results. First, the question is this causal, is this non-causal? As I said, this is consistent with results of a number of case control studies of cancer and cardiovascular diseases that I showed at the beginning of my presentation. And they all, well, not all, but nearly all, the large majority, 80% of them showed that opium increases the risk of different cancers and cardiovascular diseases. The association is relatively strong, hazard ratio of 2, which was much stronger than tobacco. So we have consistency. We have strong strengths of association. We saw dose response with duration of use. We saw risk reduction after cessation of opium exposure. When we adjusted for almost anything that we could, including age, sex, ethnic group, place of residence, tobacco smoking, education, marital status, intake of fresh fruit and vegetables, the risk declined a little bit, but remained strong. When we took a few measures to make sure that this is not reverse causality, including people who used opium after diagnosis of major diseases, or people within outcomes within the first 24 months of study. The results remained strong. And we're looking for biologic plausibility. I'm not trying to say that this is an exhaustive list, and I'm not to say that I'm going to say that we know the whole thing. There's much to be learned. But alkaloid and non-alkaloid components of opium have a number of systemic effects on, let's say, lung and bronchi. For example, these are just examples, that they cause upper airway constriction, and they cause activation of opioid receptors in medulla, resulting in reduced breathing frequency and tidal volume. So if a person has tuberculosis, or he has asthma, or he has other diseases, it's likely that this is increasing the risk of their death. On cancers, for example, there are studies that show opium or alkaloid metabolites of opium result in activating angiogenesis and neovascularization. And polycyclic aromatic hydrocarbons due to smoking can cause cancer. That we know that. There are mechanisms to show why it increases the risk of liver diseases. For example, perivenular and focal hepatocellular necrosis. So all of these show some biologic evidence. The other thing that we were concerned about was that our opium use is very different from non-opium users. And when we looked at their marital status, education, socioeconomic status, other things, they were not very different from people who did not use opium in this cohort. They use, on average, they use very low amounts of opium, about 0.6 grams per day, which is much lower than 1 to 24 grams per day reported elsewhere. These were also people who voluntarily participated in the cohort, so they were completely functional. And their follow-up rate success was more than 99%. So these are people who mostly use opium in low amounts, are not very different from other study participants, although we adjusted for almost everything. And it seems that the results of our study reflects low-dose opium over a long time, not just overdose and mortality of that nature. So implications of the study: opium and opioids are widely used, about 20 million people in the world. Death due to opium use is not limited to overdose. Seems like cardiovascular and cancer and other causes are also increased. And this study may and only may have implications for long-term use of opioids in medicine. And there was actually an editorial in BMJ about that. Let me talk finally about a couple of lessons learned and suggestions for further research. For further research, I think case-control studies of various outcomes in relationship to opium use is a very good idea to do more to establish or refute some of these associations. And this is very, very doable in Iran because there are already a good number of case-control studies. And the reason I'm not saying cohort studies, well, obviously, if people are studying cohort studies, that's a good idea to study that. But it's a bit difficult and takes a long time. When doing case control studies, it is very important to keep in mind reverse causality. So we better ask them what time when their disease started and when their opium use started, so that we make sure that opium use started way before any symptoms of disease started, so such that it is not reverse causality. It is very useful to do further studies of biologic effects of opium and opioid use and figure will increase the risk of various diseases. And it might not be a bad idea to do further investigation of long-term effects of opioid analgesics. Okay, lessons learned. As I mentioned, 10 years ago, I was very skeptic that a cohort study could be done in Golistan. But the leadership of the studies decided that they would go ahead and do it, and it did succeed. So as Nike says, just do it. You go ahead and do it. And I know there are people who are now planning cohorts in various areas of Iran, including in Shiraz and Sanandaj and Shahrud, et cetera, et cetera. I think this is a great idea. And once you start it, even if it fails, it will be a great experience. And hopefully it doesn't fail. And actually studies in Golistan, not only they start with a case control study, they did a cohort study. Now there are major trials being done there. People are trained. Lots of international collaboration. So it's just fantastic to go ahead and try our best to do the studies. Although the chances may not be high, still good to do. The second thing that I want to say, there's a story and rationale behind every study. So we started this study for esophageal cancer, but things take you where you don't necessarily expect. So when we started the study, we didn't think that opium was we're going to find that opium is associated with increased risk of, let's say, respiratory diseases or cardiovascular diseases, but that's where we are now. And for more cohorts, I know people are planning to do cohort studies in Iran. Try to do two things, in my view. Number one, try to make much of your questionnaire, maybe 80% of it, consistent with other cohorts in Iran. For example, with Golistan cohort, so that when you do the cohort, you can pull your data at the end with that Golistan cohort, and analysis with larger sample sizes can be done. But also try to make 20% unique to your area. Try to find what is unique in your area. For example, opium use was huge in Golistan. So that allowed for studies of opium use or NOS use or things of that nature. So in your area, try to find what is unique and try to do that. And leadership, collaborations, and patients, they are all very important. For the Golistan cohort, there were collaborations with NCI, with IARC, now with Mount Sinai School of Medicine, Cambridge, I have to say, also with Sweden. So this was fantastic. And leadership of the study, which included PIs from both IARC and Iran and NCI, had an important role. Particularly Dr. Malik said that his role was very, 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 very significant in moving forward these studies. If you want to read more about these studies, the opium use and was recently published in BMJ by Khademi and colleagues. The cohort of Golistan cohort is information on it in International Journal of Epidemiology, Purshams et al. And if you're interested in the history of studies of esophageal cancer in Iran, there is a paper in Archives of Iranian Medicine in 2007 that shows how the study started and we got to this point. I thank you very much for listening. And this is a picture of opium poppies. I still very much miss, the streets of Tehran, especially when there is snow. I cannot forget the good times that I have had there, and I hope you. Thank you very much for listening, and I'm ready to take questions. Thank you very much.
Thank you very much, Farin John. It was very informative. So far, we have 3 questions, actually, 2 questions and 1 raised hand. So if you want, we can start with those questions and we take more questions as well.
Absolutely.
So, yeah, can you see the questions, or I can read it for you if you want?
If you don't mind, if you can read it.
Sure, absolutely, yeah. If you go to slide 57, it says, is there
57, any... Sure.
Yeah, 57. Okay, so the question is there any change between types of opium in individuals? For example, one person may change from using Teriac to heroin.
Oh, absolutely. The questionnaire, I'm sorry.
And the question is, how did you manage these changes?
Yes, the question is, how did we manage changes if somebody switched from Teriac to Shira and vice versa? Well, the questionnaire had separate questions for Teriac, Shire, Suchte, and heroin use. So people could have used them simultaneously, or they could have changed it. And also, for each of these, we asked, let's say for Teriac, there were 6 or 7 lines below Teriac. From which age to which age did you use it? So a person could have said, I used it from 18 to 25, then stopped using Teriac, and then I had it from 28 to 36, and then I stopped it and I used it from 40 to 45. So basically, we allowed for each type, we allowed for multiple uses or switching, and we allowed for people stopping that and then resuming use. So we had all that information.
Okay, thank you.
And they were mutually adjusted for each other. The use was mutually adjusted for each other. So we had the whole thing. Any other questions?
Yeah, another question is, you've mentioned that after cessation of opium, you saw the risk reduction. Would you please explain about it?
Sure. Let me go down here. Okay. So you see on the left-hand side, current users, their risk of opium use was twofold. And most people were current users, as you see, because the confidence intervals around that are very narrow. And there are some people who formerly used opium, let's say 3 years ago, until 3 years ago, before the study started, but they had not used any opium from 3 years ago to now. So we considered them former opium users, and cessation for such a person was 3 years. So they fell into category that was less than 5 years since last time used. If somebody said, was let's say 50 years old, but said, I never used opium, I used opium until I was 38, but never used it anymore. So that person had quit using opium so that person fell in the category of 10 to 14 years since last use. And as you see from the results, the longer you had quit opium, the less risk you had. So, and there is a complete dose-response relationship here. I hope this is clear.
Okay, thank you. And we have another question as well as 2 or 3 hands raised. So we start with Dr. Ashkan Afshin, please.
Hi, can you hear me?
Yes, I can hear you.
Well, thank you very much for your very interesting and informative presentation. My question is about the exposure assessment. So given the social stigma associated with the opium use, it is expected that not all the people report their opium use accurate. So given the nature of the stigma, we expected that the misclassification in the exposure assessment not to be non-differential. So my question is, how did you deal with the potential misclassification, and how do you expect this affect the result of the study? Thank you.
So I would like to reiterate the question. The question is, people may not tell us the truth about opium use, and how does this affect the study? And this is mostly non-differential. What did we do about it? You are absolutely right that people may not disclose to us that they have used opium. But as I mentioned earlier, we did a study of the pilot phase. We did a study of self-reported opium use versus opium metabolites in urine. And sensitivity and specificity of self-reported opium use compared with opium urine metabolites was over 90%. So pretty much, at least from that study, seems like, people are really telling us, or they are disclosing to us information about opium use. That is one piece. The second piece is that physicians who practiced in the area, they said at least in that area of Iran, in Gombad, people, especially people of older ages, when they are encounter, medical groups and researchers, they would tell you the truth about, how much opium they use, which is a bit different from what you expect, in many other places. So we were not terribly about non-disclosure. However, as you mentioned, if there, and the other thing is that 8,500 people, like 17% of people said they used opium. That is a huge number. So we thought we are capturing most of the people who are really using opium. As you mentioned, if there is non-differential misclassification, if some of the people who are now considered as non-opium users are indeed opium users, then that causes non-differential misclassification. Then the hazard ratio would be actually more than 1.86 that we have found. So it may be higher than 1.86 in reality. It may be, let's say, 2.5, but or 2.2, 2.3. We have not done sensitivity analysis to see if 25% of people are not telling the truth, what the reality would be. We did not present that because we had no, from the pilot study, it seemed like only 5 or 6% of the people are not telling us the truth, and that doesn't have much of an effect on the results. But if it does, then it will be even higher than what we have found.
Oh. Okay, thank you. And
one thing, Dr. Afshin, I would be happy to receive an email from you if you have thoughts about, how to further analyze data. I would be happy to have your thoughts and comments on that.
Thank you. Dr. Danai, Gudars. Dr. Danai? Okay, let's go to Dr. Farshad Farzadfar. Dr. Farshad Farzadfar.
Hi, Farin. Thank you so much for a wonderful presentation. I have actually some thoughts about the exposure measurement. The different types and different patterns, and changing from one type to another type. It needs a lot of information that you have to collect, and it's impressive that you collected during the study. But the question is actually, is there any similar correlation or a strong correlation between smoking and opium use? If it is so, maybe we can use cumulative effect of smoking and what we call it smoking impact ratio, using the prevalence of lung cancer that you have it already, and creating a indicator such as the smoking impact ratio that can be used as a proxy for exposure of the opium use. Is there any possibility for this? Is there any strong correlation between smoking and opium use?
There is, the question is there a correlation between smoking and opium use? The answer is yes. There are people who were smokers were more likely to use opium. But correlation is not anything close to 1-to-1 or anything like that. So there is a correlation, but correlation was such that after we adjusted for smoking, age, and a number of other things, the odds ratio only was reduced from 2.26 to 1.86. So it's not anything nearly collinear or anything of that nature. We do have information on lung cancer incidence. It is not very high. It is not very high. So we can obviously do, so let me ask you a question. So the question, the comment that you are giving is that can we make an indicator of tobacco use using lung cancer incidence to adjust for opium use? Or the comment is that, can we learn about exposure to opium indirectly from lung cancer incidence? Would you talk to us about that?
Actually, the second one. If there is any possibility to, if there is a strong correlation, 1-to-1, I mean, between opium use and the smoking, then we can assume that the pattern of cumulative effect of the opium use is the same as the smoking. Then we would be able to use lung cancer incidence and create the smoking impact ratio and use this exposure, this use indicator as an exposure for opium use also. And, maybe we can, exactly what we have done in the population health metrics paper for, directly for smoking. and I was thinking if it is possible to do the same for opium use.
Unfortunately, the relationship is not nearly one-to-one. But I will check this, and I will send you the results of a 2-by-2 table of opium use and smoking.
Okay, thank you
and
so much.
if you think, based on that results, it is possible, the data are available, and doing a further analysis is definitely feasible.
Okay, thank you. Let's take another question from Dr. Mohit, Babak Mohit.
Hi, Farin, can you hear me?
Yes, I can hear you.
Excellent presentation. Thank you so much. My question was about, again, the modality of exposure. There are regions of Iran that presumably have more of an incidence of smoking, and yet we do not see as much of esophageal cancer as you're mentioning. For example, areas in southeast Iran, Kerman, but on the other hand, the modality of smoking, I think you also mentioned that mostly in Turkmen Sahara and in the Gombad region, the modality of use is through eating opium or dissolving it in beverages such as tea. Did you do any further follow-ups as to the modality of exposure to opium or the modality of use?
Okay, sure. So there are two questions here. I'm sorry, when I'm repeating the questions from the previous webinar, there was some request that the presenter repeat the question. The question is, number one, in Turkmen area of Iran, we have very high rates of esophageal cancer and high rates of opium use. There are other areas of Iran, such as Kerman and Sistan Baluchistan, that they have also very high rates of opium use, but rates of esophageal cancer are not that high. Very true. Nevertheless, opium is increasing, at least, so far in our studies, increases the risk of esophageal cancer by almost twofold in our studies. So, although it has been associated in a couple of case-control studies with increased risk of esophageal cancer, it doesn't seem to be the main driver of high rates of esophageal cancer in Turkmen area. That is only one of the drivers. So maybe this is associated with esophageal cancer, but in, let's say, Kerman or Sistan Baluchistan or in other areas of southeast Iran, there are other they do not have the other factors that contribute to high rates of esophageal cancer. The second thing that you mentioned is that modality of use, smoking versus ingestion. In Golistan cohort, when we looked at it, ingestion, well, number one, both were common, both smoking and ingestion. Ingestion was associated with a somewhat higher risk of death than smoking. But the difference between the two was not statistically significant. So ingestion was associated with a higher risk. But, when we have more cases, maybe in a couple of years, if we have, let's say, 5,000 deaths, then we may see a statistically significant difference between the two.
Okay, thank you. Another question from someone from Cambridge, UK. You refer to WHO estimation of about 30 million people who use opium in 2008 globally. Would you agree that this is underestimate? If so, and as a personal curiosity, what is your rough estimate of number of usage globally?
Well, first I would like to acknowledge that Salman was one of the first people who went to Gombad with Dr. Saidi and initiated these studies. We are very indebted to his efforts for studying these studies. Second, those 13 to 22 million are, the range is really wide. They say 13 to 22 million. And that is because they themselves acknowledge that people do not, their information is not accurate. So that is a range based on uncertainties that they mention. So unfortunately, I'm not an expert, in estimating the number of opium users around the world. So although you're right that it may be an underestimate, I cannot tell you, how much of an underestimate that would be. The people who are experts, they estimate between 13 to 22 million.
Thank you. Another question or comment, actually. Thank you for your interesting presentation. I would like to know more about the details of the statistical analysis, including sensitivity analysis. Is it possible to do it in another webinar?
Well, that goes back. Well, we can talk about that, of course. Well, number one, you can read the paper, which is being published in BMJ, and that is freely available. So it's available for free, and the statistical methods and results and discussion, talks about that. But whether or not that would be a topic of interest to people for the next webinar, I would leave it to people who organize the webinars.
Okay, thank you. There is no more question. If anybody has question or ask question that we, for some reason, didn't see them, so yeah, there is no more question. I can't see any more questions. So at this point, yeah, we can,
close the webinar.
Yes. Yeah, I'm looking. Oh, yeah, I have one more. Sorry. Dr. Gudarzdanai.
Hello, can you hear me now?
Yes, yes, Gudars, I can hear you well.
Yeah, sorry, I had a problem with my mic, which was not correctly set up. Thanks, Farin, for the wonderful presentation. And thank you also for including a lot of sort of background and context for future studies. I was curious to know your opinion about the role of the case control study in setting up context for it to be successful, which you mentioned you were pessimistic in the beginning that it would be, and also how the provision of services did affect the sort of willingness of the community there. 50,000 people, that's a huge number, to have such an sort of extensive and complete follow-up for, I guess, future people sort of designing these type of studies. How should they really think about what the community gets out of the study?
I think these are two excellent questions. Number one, I think case control study was instrumental in establishing the future cohort study.
Mm-hmm.
The reason is that at the beginning, not everybody agreed that we can do a cohort study of 50,000 people. Second, before you get to any results in a cohort study, it takes years. So some people may not have the patience to bear fruition, for a few years. Case control study was very important because everybody agreed that that's not, that's probably feasible. Second, because of the case control study, we established a clinic to which people could refer. We basically set up teams. We wrote questionnaires. We tested, the freezers and, electricity and everything in a much smaller scale. So that was, number one, a case control study, but also a pilot in itself. And so the case control study was very, very useful in building the team, making, everything in there, putting the freezers there, putting the personnel there, having endoscopies there, everything. So that helped quite a bit as a preamble to the cohort. And much of the material, like the questionnaires and everything, was later used for the cohort, and much of the methods and people who were trained and all of it. Second, a case control is somewhat complementary to esophageal cancer in many ways, to the cohort in many ways, because you make sure that there is no misclassification. For cohort, there might be misclassification of diagnosis, but for the case control, you are sure that all of them have biopsy, and we know that it's really esophageal cancer or gastric cancer. So it helps in some ways. Third, you mentioned what people get from this. Good question. Number one, people there, they got a card from the people who visited them that if they have any upper GI problems, they can refer to a track clinic and be visited for free. But that's good. They see something that is going to be done for them for free. When they had the results of initial bloods and other things, they would be communicated and said, this is your blood, results, which they were happy. When they had, let's say, they measured the blood pressure, which was part of the study, or weight and things of that nature, that would be reported to them so that they know they have hypertension or they do not, or, they have, let's say, what is their height and weight and that nature. So there were some incentives for people to participate in the study. and incentives including coming to the clinic, some lab results, and people try to be respectful to them, and all of that. So it is really important that the leadership of the study decided that people would get something, physicians in the area would get something, university officials would get something, researchers around the world would get something, so that it's a win-win-win situation for everybody.
Fantastic, thank you.
Thank you very much, Dr. Kamangar. It was excellent, and thank you everybody for joining us. Don't forget, we have these seminars or webinars on the second Friday of each month. Hope to see all of you next month, second Friday. Just mark your calendar. Thank you very much,
Thank you
and
very much.
have a great time.
Thank you for organizing. Thank you for participating. Thank you very much. Bye.
Thank you. Bye.